NEDA is a very big echocardiographic registry. So we set NEDA up originally because we had demonstrated that pulmonary hypertension was actually much more common than had previously been found, and we found that from a local region in Western Australia. And so to prove that we were right with this, we wanted to show the biggest database that we could across the biggest area that we could. So we set up a national echo database throughout Australia. So we called it NEDA, and it was intended to try and find thresholds at which mortality starts to increase for various different echocardiographic variables. And this was linked with mortality through the National Deaths Index of Australia. We know that heart failure has different morphologies and different presentations, but from an echo perspective, there are really two major forms of heart failure. There's systolic heart failure and diastolic heart failure. And we know that diastolic dysfunction as an abnormality found on echo, it can result in heart failure, subsequent mortality, and there's no really effective reversal treatment, but a diagnosis is still extremely important, both for making it clear what is causing the patient's symptoms, as well as helping to direct where the investigations and treatment for that patient would be directed. So the current diagnosis of diastolic function is really based on a set of guideline criteria. So the 2016 ESC EACVI criteria for diastolic function are based on a series of parameters. And one of the problems is that, first of all, there's no categorization based on age. So age is not a factor in the current guidelines. And as well as that, there's a lot of indeterminate diastolic function. We wanted to explore this in more detail. So our two aims were, first of all, to describe the guideline-based diastolic function using the current criteria, but across an entire nationwide cohort linked with mortality. And then the second thing we wanted to do was to examine the pattern of mortality of the statistical distribution of each of the main parameters that make up the diastolic function criteria. So what we did was we took the entire NEDA registry, and this iteration that we examined was NEDA 2.0, which was extracted on the 1st of January 2020. And we took all individuals that had at least one diastolic function measurement and everyone that had linkage with the National Deaths Index, and then we applied the ASC EICVI algorithm. So we had 436,360 individuals to work with, and then the algorithm was based on those with normal ejection fraction, those with abnormal ejection fraction, so the cut point being 50% based on the guidelines. And then we used all of the current recommendations to describe whether the diastolic function in the preserved group was normal or abnormal, or whether they had indeterminate diastolic function. And then in the impaired ejection fraction group, we used we looked at the filling pressure categorization as per guidelines, which was either normal filling pressure, increased filling pressure, or indeterminate filling pressure. And so as we went through this, we ended up with we started with 631,000 individuals greater than 18 years. Then we had to exclude those with no diastolic function measurements, and so the final number that we could analyse was 436,360 individuals, which were equally split between men and women. And then if there was no measured left ventricular ejection fraction, then we couldn't apply the algorithm to them, and so we ended up with breaking it down to those who didn't have enough diastolic function measurements of other types as well, being able to measure diastolic function in the majority, but certainly not all people in the cohort. Now, the important take-home message from this, though, was that we had indeterminate diastolic function in 21.5% of those who had normal ejection fraction, and then those with those with impaired ejection fraction, we had indeterminate filling pressure in 62.2%. So a big proportion of people had no measurable diastolic function based on the algorithm of the ASC EACVI. So we looked at in order to establish the place for the individual measurements as far as mortality risk was concerned, as well as the place for diastolic function measurements based on the guidelines. We used the standard approach of the guidelines themselves and looked at both the long-term mortality over an extended period of follow-up, as well as the 5-year adjusted cardiovascular-related mortality. And this was adjusted for a number of different variables, which I'll come back to in a short time. And then we also looked at not just the guidelines, but then we looked at the individual parameters, again, looking over an extended period of time for Cox proportional hazard adjusted for age and sex. And then we also looked at the 5-year cardiovascular-related mortality adjusted for a number of different variables. And then we looked at these both for the guidelines as well as the individual variables. We chose the 4 most representative individual measurements within the NEDA cohort that represented diastolic function the closest. Looking through this, the standard classification to start with. So I mentioned that I looked at we looked at the long-term outcome based on Cox proportional hazard models, and you can see, and I've got the slide up here on the screen that there is the long-term all-cause mortality adjusted for age and sex on the left-hand side for preserved ejection fraction, so the ejection fraction greater than 50%, you can see there's really a very small difference between those with normal, abnormal diastolic function and those with indeterminate diastolic function. Even though there is a separation with a significant p-value, you can see that over a long-term follow-up of about 24 years, there was very little difference between those groups. Whereas on the right-hand side, you can see that the impaired left ventricular ejection fraction group, there was a much bigger separation between those with normal filling pressures, which is the blue line, the increased filling pressures, which is the red line, and then the indeterminate filling pressure was indeterminate between those two lines. But there was still an increase in the mortality risk for indeterminate filling pressure compared with normal filling pressure. So then we moved on to do the 5-year adjusted cardiovascular mortality. So I've got that slide up for you now, and you can see that there is that in the preserved EF algorithm, that for the reference group, which is normal, you can see that there is a clearly increased mortality risk. So this is 5-year adjusted cardiovascular risk, and the adjustments were for age per year of increment, male gender, BMI per unit increase, ejection fraction per unit increase, valvular heart disease, non-sinus rhythm, and then aortic or mitral valve replacement. So it's quite an extensive set of adjustments. Obviously, it doesn't adjust for all possible things, but it is well adjusted in this analysis. But interestingly, also the indeterminate group was what also had an increase in their risk of 5-year cardiovascular mortality and all-cause mortality. With the impaired EF group, there was again an increased risk of 5-year adjusted mortality for both cardiovascular and all-cause mortality in the increased filling pressure group compared with the reference group. The indeterminate group did have a numerical increase, but it wasn't statistically significant since the lower limits of the confidence interval crossed the 1.0 odds ratio mark. So then turning on to the individual parameters, you can see here that we've chosen the 4 most representative parameters, which I said we would do at the outset, and they were E-wave velocity, the E-prime velocity, the E to E-prime ratio, and the left atrial volume index. So going through each one of them, the E-wave velocity, you can see on the top left that there was a very clear spread, those with the lowest E-wave velocity to the highest E-wave velocity, and the highest E-wave velocity clearly had the worst long-term survival. The E-prime velocity, the same thing, but in reverse. So the lowest E-prime velocity had the worst survival. E to E-prime ratio, the highest E to E-prime ratio had the worst survival. And then left atrial volume index, the highest left atrial volume index had the worst long-term survival. But there's a really clear way to look at this, and this is this one I've now got up on the screen, which is the 5-year adjusted cardiovascular mortality. You can see here there's a clear threshold. So again, adjusted for the same things that we adjusted for with the standard algorithm. So age male sex, left ventricular ejection fraction, non-sinus rhythm, valvular heart disease, and mitral or aortic valve replacement. So with the E wave velocity, there's a threshold at which mortality increases, and that's when the E wave velocity goes above 90 centimeters per second. There's another threshold, and that's with the E prime velocity when it drops below 9 centimeters per second. On the bottom left, you can see the E to E prime ratio, and that's the mortality threshold is at 9, the ratio of 9. And then with left atrial volume index, or LAVI, it's above 32 mils per meter squared. And these are very clear cut points. And you can see that the granular importance of this is that when you have a patient with a very low E prime velocity, let's say less than 4, then they have an over 2 times increased risk of long-term and also 5-year adjusted mortality. So there is a nuance in here. It's not just an on-off thing. There's an increase in mortality based on the severity of the deviation away from that threshold. We need to take into account that there are many different things that can cause diastolic function. And we all acknowledge that diastolic function is a complex process. It's not just one single thing that goes wrong that causes diastolic function. So there's lots of individual diseases that can affect the parameters differently. But we can't take away from the fact that even after adjustment, there is this clear threshold of mortality. So we believe that despite the multitude of causes of diastolic function, these thresholds are clinically important. The second thing we want to acknowledge is that this is real-world observational data. So this is not clinical trial data. It's not derived from clinical trials. These are patients who present for clinical indications to a clinical echo lab. But we do have some clinical information that's lacking. So, for example, we know that people were referred in for heart failure diagnoses, but we don't know every patient with a heart failure diagnosis. We don't have hospitalization data or revascularization. And so that's something we're going to be doing with future iterations of NEDA, but it's not in this current version. So it's possible our data is not applicable to all populations, and that needs to be taken into account. We don't know everybody's rhythm. So where rhythm was documented, we clearly took that. But where rhythm wasn't documented, we tried to get a surrogate such as E to A ratio. So if the E to A ratio was present, so there was an A wave, then that was indicative of a sinus rhythm. But if there was no A wave, then we assumed that was an atrial arrhythmia, most likely atrial fibrillation, and so we excluded them from the analysis. We also took the last echo as part of this analysis, but taking the first echo we did as a sensitivity analysis to see if the results would change, and they didn't change at all. So I think that probably that didn't influence the results. So with those caveats, our conclusion from this data is that the ESC EACVI guidelines do correctly identify an increased mortality risk in both the preserved ejection fraction and the impaired ejection fraction groups. But there was a high proportion of people with indeterminate diastolic function, which fits with what we see clinically. 21.5% overall and 62.5% in the impaired LVEF group. So this really means that we need to start to look at other factors if we want to identify what's going on with these people. And looking at those other factors, we found that the 4 most representative individual parameters were very informative. And so the E wave velocity at 90 centimeters per second, the septal E prime velocity at 9 centimeters a second, the E to E prime ratio at 9, and the left atrial volume index at 32 mils per meter squared gave a really good threshold of mortality. And the further deviating away from that threshold, the more the risk of mortality. Left ventricular ejection fraction and age do have important influences on diastolic function, and we believe this should be reflected in future guidelines. But sex doesn't seem to have any influence on these results, so that may not be something that's relevant for guideline changes in the future. But certainly we believe that ejection fraction and age are important determinants and should be taken into account. That's why we took them into account when we did our corrections in the multivariate model. So the take-home message from this is that yes, guidelines are important, and the guidelines are very informative and give us important information, but we don't want to take guidelines purely in isolation. They're taken in the context of other measurements and the individual parameters, and particularly deviations of those parameters a long way from the threshold of mortality will give you a lot of information about what's going on with your patient. So as far as changes to guidelines are concerned, Obviously, there's a lot of things to take into account, and we also acknowledge again that diastolic function abnormalities are complex, and there's specific diseases with specific cut points that are relevant to that individual disease. But these cut points that I described earlier of the E wave velocity at 90 centimeters per second, the E prime velocity at 9 centimeters per second, the E to E prime ratio at 9, and the left atrial volume index at 32 mils per meter squared. Each of those is relevant from a threshold point of view. Further deviations away from that increase the risk of mortality. And so we think that this is something that would be directly relevant to future guidelines. So the next steps for us is that we would like to verify this in a clinical cohort that we know all of the clinical granularity on. So our plan is to look at this in hospitalization cohorts, to look at it in individual disease cohorts, people who presented with heart failure, people who've had cardiac intervention, coronary disease, bypass surgery, etc. And so I think we really need to have a granular understanding of the individual caveats and the individual different types of abnormalities that can cause diastolic function abnormalities. And so that is a future plan for us. And I think that this is something that we'd like to see in other areas around the world, is to expand the registry data to be able to look at mortality risk in big cohorts with lots of clinical granularity. So I had the privilege of presenting this data at the late breaking science session of the European Society of Cardiology. In fact, it was the first session of the Congress. And we have this publication coming up very shortly in the European Heart Journal Cardiovascular Imaging.